Hello, everyone. My name is Matthew Woodward. I am a movement disorder specialist working at the Allegheny Health Network, presenting a topic, Parkinson Disease 101, with a focus on medication and early initiation of things for the Parkinson's Foundation of Western Pennsylvania. I'm going to change this just a little bit so I'm a little smaller. You can see the presentation a little better. So, a brief discussion about our objectives today. We're going to talk a little bit about a brief overview of Parkinson's disease, and then some of the motor versus non-motor symptoms of Parkinson's, goals of treatment, some of the various medication options and side effects that can be associated with them, timing of medication, what does your neurologist or movement disorder specialist want to know? So, Parkinson's disease, this is a loss of dopamine cells in the brain in an area of the brain we call the basal ganglia, which you can see in the bottom right there. The UK Parkinson disease brain bank criteria for Parkinsonism, which is a collection of symptoms that we see in Parkinson disease as well as other conditions, include the cardinal feature of bradykinesia, which is a slow movement with interruptions and decrement, things getting tinier and tinier. Things like muscle rigidity or stiffness, tremor that often occurs at rest, reduced facial expression, shuffling of gait, posture being stooped, soft voice, amongst other things. You can also have changes to your balance or falls as part of this criteria. When we treat Parkinson's disease, the main mechanism of why we're treating or how we treat it is by adding or assisting to the body's current dopamine supply within the brain. Parkinson's disease can be associated with what we call both motor symptoms as well as non-motor symptoms. Motor symptoms are kind of the more typical symptoms we see with people with Parkinson's disease or think about with Parkinson's disease. So those are the things like slowness or stiffness. Maybe movements are interrupted or freezing can happen in the feet or the legs, balance issues and falls. But then, as you can really see in that iceberg there are a lot more symptoms, and a lot of those probably fall into this non-motor or non-movement category. So things like mood changes, anxiety, depression, apathy, bowel and bladder dysfunction, high pressures and low pressures, both existing sometimes at once, where it's high when you're sitting and then you stand and it drops very low and you get dizzy or lightheaded. There can be issues with sleep. There can be issues with intimacy. So, our goals of treatment for Parkinson's disease are symptomatic therapies. We unfortunately do not have any disease modifying medications yet, but there is something that I'll talk about a little bit later, which has disease modifying effect in slowing progression down. So, please stay tuned. Our goal with treatment is to improve quality of life and function. But also importantly, are there other specific goals for you? As far as Parkinson's medications go, probably the main class of medication and the ones we're going to use the most often are dopamine replacement therapy. And this is with primarily levodopa. So this is replacing the lost dopamine in the brain. It is the gold standard therapy since the 1970s. And from the American Academy of Neurology, or AHN, it's recommended as the initial therapy for Parkinson's disease. The main formulation of this will be carbidopa levodopa. Some people call it CL or carbi-levo, or the old brand name Sinemet, which is Latin for without vomiting, in different formulations. So there are multiple oral formulations like immediate release, controlled release or CR, extended release, such as Rytary or Crexont with some immediate release in there. And the way this works is levodopa becomes dopamine in the brain, and then your brain can use that for movement and other Parkinson's related symptoms. So carbidopa prevents the GI breakdown of levodopa. And sometimes you'll hear some of us talk about CR. Why not just put you on a controlled release formulation? Because it's not as bioavailable. There may be a lower peak dose. Sometimes the release of it is a little bit spotty. These medications are generally best on an empty stomach. So something like 30 minutes before or 1 hour after a meal. Or at least if you need to take it with a little bit of food, minimizing the protein of that food will be beneficial, as this can decrease the absorption. There are also other forms of levodopa, carbidopa, including inhaled forms, intestinal, subcutaneous, and often we are discussing these medications kind of further down the line. Now, common side effects for levodopa or carbidopa levodopa include things like nausea, low blood pressures, and dizziness, something called levodopa-induced dyskinesias, which are these extra wiggly movements that are non-rhythmic. They don't have kind of a similar up and down or left and right sort of quality to a tremor, where it's more kind of dance-like and flowing. If you have seen Michael J. Fox before and how he kind of constantly is moving around and wiggling, that's dyskinesia. At higher doses later in the disease, we may expect things like hallucinations, but we don't always expect those early on. Now, this is just a graph of some of the different carbidopa-levodopa release formulations. So you can see why there are reasons we may be using some of these different medications in different ways. So you have in the blue, light blue, the carbidopa-levodopa immediate release, or Cinemet, which has a nice early peak and then slowly kind of goes out of your system over a few hours. Then you see something like the control release, the Cinemet CR, which has a much smaller peak, but maybe a slower duration of action. Then you have something like Rytary, which is a combination of immediate release and extended release, which you see the immediate release starting first, keeping you at a bit of a steadier dose, and then slowly downtrending over a few hours. In theory, in practice, this doesn't always work the same way, and some of that comes down to absorption and other factors specific to your body. But this is a general sort of appearance. And then the Stalevo there is a combination of carbidopa-levodopa as well as a medication called entacapone, which helps extend the medication action a little bit, and I'll speak about a bit later. So other medications. There are other medications like dopamine agonists that mimic brain dopamine, such as pramipexole, also called Mirapex, or Pinarol, or Requip, or a cutaneous patch, rotigotine patch, that you wear for 24 hours at a time. That brand name is called Nupro. Some of these do have some unique side effects, which may limit their use in some scenarios, such as things like sleep attacks, where you're in the middle of conversation or eating or at a stoplight and you suddenly fall asleep. Impulse control disorders, so excessive shopping, gambling, internet use, putting things together and taking them apart again. There is a rash that can be seen on the lower extremities, or a more risk of low blood pressure and hallucinations compared to levodopa. Additionally, there are what we call COMT inhibitors, which help to keep the levodopa around longer, and probably on average adds about 30 minutes or so of what we call on time, or when your medication is working well, per dose of carbidopa-levodopa. So by itself, it doesn't do anything. It needs the levodopa in order to work. There are forms like entacapone or Comtan, which is dosed with every pill of the carbidopa-levodopa in whatever form, or something like opicapone or Ongentys, which is a once daily formulation and still brand name only. And like I mentioned earlier, there are these combination pills like Stalevo, where you have both carbidopa-levodopa and entacapone all in the same pill. There are some unique side effects involved with this, such as change in body fluid colors, so urine, sweat, and this can lead to stained clothes, as well as diarrhea. There are a class of medications called MAO-B or MAO-B inhibitors, which prevent the dopamine breakdown in the brain. And so the two main ones you're going to maybe hear about, or your doctor may recommend, or provider may recommend, is rasagiline, old brand name is Azilect, and selegiline, old brand name Eldepril. These generally have a mild to modest benefit, and so it may be something that we use to sort of dial in your current dose just a little bit, as opposed to something that is going to make a huge difference. And maybe there are some unique sort of mechanisms to it as well, which may help with some other symptoms we see in Parkinson's disease. Unique side effects wise, sometimes there can be headaches. Very, very rarely is there a condition called serotonin syndrome where you become confused and feverish and to the point of what we call altered mental status or delirium. This is very unlikely. There have been large studies to show that the use of these medications in combination with other medications, such as antidepressants or pain medications, is a very unlikely chance of developing serotonin syndrome. But pharmacists will sometimes still flag this medication or tell you that you need to talk to your doctor about taking this with certain medications. And that should always be a personalized discussion, but oftentimes we will be comfortable using some of these medications in conjunction. Additionally, there is a couple different versions of amantadine, an immediate release formulation, as well as an extended release formulation, Simitrel and Gocovri brand names, respectively, that generally also tend to have a mild to modest Parkinsonian benefit. So to the things like tremor and stiffness and slowness, etc. In general, more so now amongst movement disorder specialists, this medication is used more so for dyskinesia. Again, that extra wiggly, you can't sit still kind of movement. So if the dose of carbidopa-levodopa is good for you, but you get this bothersome dyskinesia, sometimes we can add this amantadine to your medication to help with these effects. Some of the unique side effects of this, you may have this cosmetic-only rash on the legs, which is generally not itchy or raised or painful, insomnia or trouble sleeping. So we often will dose this early, although Gocovri is dosed at bedtime so that it slowly releases overnight and into the morning. And I do tend to expect more in terms of hallucinations with this medication in those who are older with other medical issues. There is older medications out there too that used to be used with more frequency, such as trihexyphenidyl, or old brand name was Artane, which was mostly used for tremor. And it's a class of medications called an anticholinergic. So it is in the same class as something like Benadryl. And so it can have similar side effects to that, like dry mouth, urinary retention, confusion. And so it is not as frequently prescribed as it used to be. Istradefylline, or brand name Nurians, is a newer medication that is still brand name only, which maybe has a mild to modest benefit as well. Similar side effect profile as some of the other medications we spoke about. And again, is maybe sort of a medication to help us dial in the right dose for you as opposed to being used by itself. So, a question that is asked a lot and probably was asked more so in the past is there any benefit in waiting to start medication? And so there is generally no need to wait to start medication, as this has been well studied over the years. We know it's not the levodopa itself that causes problems compared to the progression of the Parkinson disease interacting with the medication that is causing problems. So we know now that this is not toxic to the brain. You don't only get so many good years on the medication if you start it early. Things like dyskinesia and motor fluctuations, which I'll discuss, will happen regardless or can happen regardless of when you start your medications due to the Parkinson's itself. And if your symptoms are bothersome to you, causing falls, preventing you from doing the things that you need or want to do day to day, it may be worth starting medication. But at the end of the day, this is a symptomatic treatment, and so medication can be delayed if you feel that you do not need it. If you have a tremor and it doesn't bother you, or you get around okay, or like I said, you're doing all the things you need to do on a regular basis without issue. As far as timing of medication goes, a consistent dose and consistent timing may not be as important at the start, and you may not necessarily notice a kicking in and wearing off of the medication. But if you go without it for a few days, maybe you start to notice a difference. But that can change with time, where you may start to have that off and on sort of feeling between doses. And that's due to the natural brain dopamine waning over time and maybe more need for medication to help restore that balance. When we talk about off time, we're usually talking about when meds are not working as well as they could or working at all. And like I said, that can start to occur between the doses or as you're slowly getting towards your next dose 30 minutes before, an hour before. You can also have motor fluctuations, which can be related to the timing and the dosage. So wearing off earlier than usual, or the dose just doesn't seem to work the same way as your first dose of the day, or peak dose side effects like that dyskinesia that we spoke about. So I want to emphasize that medication dosage, timing, and frequency is often expected to change over time as we treat Parkinson's disease and is a normal part of PD management. Now, I had mentioned that there was a disease-modifying therapy out there. And so if we could prescribe this to everyone, we would, and in a way we do. And this is regular aerobic exercise. So we often will use the American Heart Association guidelines of 150 minutes weekly of moderate aerobic activity. And so this should be enough where you're a little bit winded, your heart rate's going up a little bit, but it's not your maximal effort. You could still have a conversation in between breaths. And one thing that I discuss frequently with my patients is the most important thing is you need to find something that you enjoy doing or at least can stick with regularly. So if I tell you to run and you don't like to run, then it doesn't matter. But if you like getting in the pool or you like doing the rock steady boxing classes or another boxing association class, then that's good. Another thing that I find important is that you should be trying to find things that you can do year round. If you live in the Western Pennsylvania area, you know our winters can be long at times and not ideal for going outside and doing things when the weather is nice. And so finding things that you can do indoors at home or community gym or something along those lines is very important. So people sometimes will ask me also, what do I want to know? What does your movement disorder specialist want to know? And so there can be a lot, or there can be a couple things. Not every visit will we discuss all of these things. If things are going okay, maybe we can spread out appointments and check in less frequently. Maybe it's a quick little thing that you can shoot a message through your MyChart or your patient portal or some other messaging system or give us a call. I think what's important to start with is what your goals for the appointment are today. And what are your goals for treatment? You want to tell us about specific symptoms you may feel due to your Parkinson's, or whether that's motor or non-motor in nature. We want to know the timing of these symptoms. You know, does it seem to be medication related, like an hour or two after your dose? Or is it symptoms when you're coming up on your next dose, 30 minutes or an hour before? Is there a time of day where you have more symptoms? Is it more when you're stressed or anxious, which is very typical? Do you have side effects to the medication, such as dyskinesia, like we spoke about? Do you get dizzy? Do you get lightheaded? Is there nausea associated? Because there are some ways that we can potentially manage these symptoms and side effects. Timing of doses with food, without food can be helpful for us to know too. Are you exercising regularly? Again, that's the disease modifying therapy. Are you having falls or near falls or balance issues? Do you have trouble swallowing? How is your mood? Any issues with bowel and bladder function? And these are only a few things that I may ask about or that you may want to discuss with us. And that's part of seeing us regularly so we can make sure that we speak about all these different things. And last but not least, I think it's important to get connected. And so you have a great local organization in the Parkinson Foundation in Western Pennsylvania. There are great national organizations like the Michael J. Fox Foundation, amongst others, as well as local community support groups and exercise classes. And so I encourage you to get involved. Online communities can be helpful, but just know that anyone can post anything, and so you have to take everything with a grain of salt. And if you've met one person with Parkinson's disease, you've only met one person with Parkinson's disease. And so the things that work for you compared to what might work for them can be very different. And so with that, I just wanted to say thank you. I appreciate you tuning in and listening to some of this discussion. And please get connected, like I said. Thank you.